Okay, first meningitis we're going to discuss is Neisseria meningitidis. It's gram-negative diplococci. Okay, gram-negative. Okay, this is the first gram-negative cocci we've talked about. Up till now, they've all been gram-positives like staph, strep. Diplococci. Diplo meaning two. Two spheres that will always seem to be stuck together. That's what this looks like when you go and you gram stain it. This is one of them that they worry about for in schools. This is one of them they worry about in your dorm rooms. They see this one's an outbreak. Okay, you'll get an epidemic, an outbreak at a school or in a dorm. This one's high, as we're going to see in a later slide, is highly communicable. (15 to 20% of all clinical cases that are meningitis, that are diagnosed as a meningitis, is going to be Neisseria meningitidis. So this one is highly prevalent. And unfortunately, it's highly prevalent and a very serious infection. We'll see this predominantly in young children. Turns out Neisseria meningitidis comes in what they refer to as strains. So genus Neisseria, species meningitidis, strains A, B, C, D, and so on. Why do they break them up at A, B, C, D, and so on? Well, certain surface proteins, they're going to be different between strain A, strain B, and strain C. So they're able to group them like with like, both the surface proteins and genetically, because remember, to have the special surface protein at a special shape means you have to have a gene that's calling for that specific shape. And they have found that what they refer to as serotypes, B, C, and Y, are most prevalent. Bacteria enters in by you breathing in respiratory droplets. Somebody else who may be in that incubation period, shedding bacteria, coughs, breathes. You breathe in the micro droplets, it settles out in your throat. Starts to colonize as a transient, colonizes and is able to penetrate through the epithelial lining of your throat and nasopharynx. Penetrates deep enough and starts to colonize the meninges. Its ability to penetrate is due to certain toxins that will damage tissues. Those toxins will also alter circulation. More blood flowing into an area, more inflammation going into an area, which means that you're also going to get more white blood cells, macrophages, neutrophils. Macrophages, neutrophils are heavy-handed. Start damaging more and more of the tissues there as they are trying to find and kill anything not you. Leads to hemorrhaging, leads to bleeding in a certain area, which just opens up more and more of the underlying tissues, allowing the bacteria to penetrate deeper and deeper. You'll end up with some mild remodeling of the tissues in the bone at the area as the bacteria penetrates and then settles out on the meninges. And all this actually happens rather quickly. Okay, it's only a few days incubation period. As this is occurring, you start to feel worse, worse, and worse, and next thing you know, you're spiking a fever, sore throat, chills. Almost sounds like, hey, the beginning of the flu. Next thing you know, patient is suffering from delirium. As it increases and the disease progresses, you start to see more and more symptoms that are showing signs or issues throughout the body. Bleeding under the skin. Well, because this is those toxins and stuff they're showing symptoms of toxemia. The toxin is in the bloodstream and it is going everywhere, causing damage to the capillary beds, bleeding, white blood cells, inflammation in other areas throughout the body, which is going to lead to large bruises appearing. Those bruises are still going to keep collecting blood. That blood's going to coagulate and it's going to start to turn black. As this continues, blood volume drops, blood pressure drops, going to go into shock. Shock increases, the delirium, the coma, both from compression of the central nervous system as well as the advancement of how bad their shock is, will lead to cardiac failure. Cardiac failure as well as adrenal glands and kidney damage. Death will be in a few hours. So once it hits and it's able to get past the throat, the progression of Neisseria meningitidis derived meningitis is swift and brutal. This is generally communicable, person to person. Okay, Neisseria meningitidis does not like to be in the environment long. It's not one of these, somebody sneezed on their hand, touched a doorknob, you touched the doorknob, and now you've contracted it. No. We are the only reservoirs, okay? There's no there's no mechanical vector, there are no biological vectors, it's not passed by, insect bites or anything like that. Person to person. The timing of this, late winter, early spring. Lots of people indoors around each other 24/7. There's no getting outside. Turns out sunlight and fresh air is a great disinfectant. Not everybody who has Neisseria meningitidis in their throat, their nasopharynx, is going to get sick. There are carriers out there. They're carriers, and every time they cough, they sneeze, they breathe out. They're putting that out in the environment in micro droplets that somebody else may breathe in. You think somebody has bacterial meningitis. This is a medical emergency, okay? This is not something, hey, let's wait and see how they are tomorrow. Or this is, hey, I made a doctor's appointment for later this afternoon. Just lay there for a while. No, this is either you call an ambulance or you pack them in the car and you drive them to the nearest ER immediately. Okay? Once there, they're going to do the battery of tests. How's your head? What's it feel like? Do the lights in the eye, see if they jerk, see if they can't handle the light in the eye. Can you move your head around? Can you touch your chin to your chest? Do you have a fever? Things like that. Do they have a rash? Are they doing, the little things, bruising around, things like that. And they're going to immediately begin, with the onset that this is meningitis, and they're going to start with some of the worst ones first. Let's rule out the worst, the bad, the worst of the worst first. so that hopefully it's not, while all meningitis cases are bad, some are worse than others. So with that idea, you're going to treat for the worst of the worst first. You're going to treat with antibiotics and fluids that are broad spectrum, but within that spectrum, they can definitely affect Neisseria meningitidis. Once you've taken the cerebral spinal fluid, the blood, the swabs of, either the nose, the throat, and send those off, it's going to take hours for, half a day, maybe a day before the ID lab's able to send information back. So you treat as though it's the worst of the worst first, and you do it heavy-handedly. So that way you're treating in such a way that you're getting them all, but no matter what, Neisseria, if it's the one, you've got that covered. Infection rate is only 1%, which is a saving grace, okay? Well, you're going to get exposed, who knows when, today, tomorrow, hey, both days, maybe not till next week or the week after. Of the people who get exposed, only 1% will develop a disease. Even treated, even when patients seek treatment, Neisseria meningitis, also known clinically as meningococci, meningococcineal disease, meningococcus, has a 15% mortality rate. That means of the people who do show up at the ER and you think you've caught them early enough or somewhere in the progression of the disease, you start the high dose, broadest spectrum antibiotics, you throw everything at them, there's still a 15% chance that they're not going to make it. If a patient, somebody who's suffering from meningococcus, does not seek treatment, it is 100% fatal. What's interesting though, treatment, penicillin G. Penicillin actually still works. Now, you're not just going to throw penicillin at the patient who presents. Yes, they're showing all the, classical symptoms of meningitis. Let me just throw penicillin G at them. No, you're going to throw a cocktail at them. But within that cocktail will be penicillin G.